something smelling good on.
Are you very, very north?
Alright, and it's gonna take me a little while to grade the homework, so I'll get those back to you by Wednesday. Give me a second, I'll see you 3 back real quick.
Do you have any extra copies of that, thing? I need to make a copy of it.
I'll give it back to you once I get it.
No, like a blank one.
A blank
I
one.
meant to make a copy of that one that I forgot.
I don't know. Surely I do something. Ready to get your in-class 3. You don't have it? Dave, did you give me yours or show it to me?
I don't even have a sheet.
Okay. Did you email yours? What? Your week 3 in class? No, I didn't.
Did you just give it back there?
Yeah, I know. I was like, did you email it to me? Okay, I just didn't have your grade in there. I thought I had it. Okay.
Gotta bring it back or bring it
Yeah. It's midterm. Oh, that's what it says. Okay. I thought y'all just doing this. I was like, did we have
Are they only go to the same day or those two?
No, they're on different days. You have your, your election on different days.
Is this what you just asked me for?
Well, for 3, week 3 in class. Okay. So we stopped on page 956, right? After the on sonographic technique?
Yeah.
Okay.
Oh.
Yeah. Okay. I guess we're right here. Okay, so sonographic technique. The female pelvis, you guys have already said this a bunch of times, is seen transabdominally and transvaginally. Transabdominally, you need a full bladder. Transvaginally, you need an empty bladder. The transabdominal is done on top of the anterior abdominal wall. You guys know that you've been doing it. But the transvaginal ultrasound is done through you insert the probe in the vagina, and it gets you much closer to what you're actually looking at, to the uterus and the cervix, and being able to see much better detail transvaginally. Whereas transabdominally, you have a better window. You can move further and see more, because whenever you have that probe in the vagina, you can only move it so far. Well, with transabdominal, you can move and you have a wider field of view. Alright, box 41 on the next page, 957, that has a lot of good information in there that, you document, whenever you're doing an ultrasound of the pelvis, you need to document the uterine size, shape, and the orientation. So you're going to be scanning through the uterus and taking those pictures as if you were doing a flip book of the scene, right? On the new machines, you can do a capture, where you hit capture, you scan through, and then you hit capture again, and it does a clip. And whenever you pull it up on PACS, instead of seeing a still image, you'll see a clip that just keeps playing on loop. And so that's what you're going to be scanning through the uterus or an ovary, a liver, whatever. Whenever you scan through anything, that's what you're going to be doing. Whenever you look at any kind of structure. You need to really see the endometrium and the myometrium. You know, the serosa or the perimetrium, that outer layer of the uterus, you don't see that on ultrasound, really. You just see the homogeneous myometrium, which is like that low to medium echo gray around the endometrium. And you guys already know the endometrium varies with whatever stage or whatever part of the cycle that your patient is in. And also, you need to document the cervix. You measure the length of the uterus from fundus to cervix. So my drawing that I have up in the lab still, I think everybody has got it now, measuring the uterus correctly, to fundus to cervix, and then you measure where it's widest for the height measurement or the depth measurement. Same thing. Also, if you see anterior posterior or just AP, if it's something that says like your AP measure, that's what this is, because you're going anterior to posterior. Alright, so this is that measurement, and you're going to go perpendicular to this, so that whenever you were to do like dots, it would make like a T. Okay? And then in transverse, we always use our endometrium as our guide. And then you measure just across like that. So whenever you're looking at myometrium here, just kind of, endometrium, just use that and go through here. And in some people, it may alter, and one may be like kind of up here and then go down. I think one of y'all that does that, and it kind of confuses on how to measure. Just pick one. You don't have to be perfectly across it. Just try and get as close to it as you can, because that is midline. So it's okay if you come a little bit off of it, because their anatomy kind of deviates a little bit. That's fine. Okay. So your AP depth, that's what that is again, or just the AP depth. So depth, height, AP, all that's the same thing. That's this measurement right here. And it's anterior to posterior walls, and it needs to be perpendicular to the length. Width measured from transverse or coronal view, because whenever you're doing a transvaginal, technically it's coronal, not transverse. But still, everywhere you go, it's still labeled as transverse. There may be some site, though, that does say coronal, but most that I've all seen, they still do transverse, which, if that's just what the radiologist is used to, that's fine, not a big deal. All right, and then the cervical diameters, that is with pregnancy, and I have an image of the cervix. I think it's for the next chapter, though. But if you were to see, like, a baby in here, could you see the cervix much better? If you have like a baby and all this is blacked out, you can see the cervix much better, and you have to measure that cervix. Because with pregnancy, the cervix, it dilates and it spaces, right? Thins out. Well, that's what that length is for. And we'll talk more about that next chapter. Alright, endometrium analyzed for thickness and echogenicity. You guys are already doing that. You're measuring that endometrium. What's a normal endometrium measure less than? 14 millimeters. That is what A normal menarcheal endometrium should measure less than. What about someone that is postmenopausal? That's not on hormone replacement therapy. Less than 5 millimeters. Yes. All right. Myometrium, cervix, evaluated for contour changes, echogenicity, and masses. These, the contour changes, the echogenicity, all that kind of can go with masses. We'll talk about fibroids or leiomyomas or myomas, it's all the same thing. We'll talk about that too whenever we get to the next chapter. But this is what all you're doing whenever you're looking at the uterus. Alright, so here is how you measure a uterus, and this is a good one. You can see very well, the bladder's not even all the way full. But measuring from fundus, kind of using the endometrium as its guide, going down to the cervix, and then the AP depth, or the height, or the depth measurement there, that is perpendicular to the length measurement. That's a normal measurement there. Here's another one. Just the length, all the way from fundus to cervix, and then the AP depth measurement. And here's the transverse. Using the endometrium as the guide, go straight across. And here it is in a transvaginal ultrasound. I'm going to turn the lights off for this one. See this frozen. But, so what kind of uterus does this patient have? Anteverted or retroverted?
Anyway.
Anteverted. What would it look like if it was retroverted?
Left down.
Well, on transvaginal ultrasound, it looks backwards. The fundus would be over here, and the cervix would be over here. So whenever you do put your probe in, you're doing a transvaginal, it looks backwards, make sure that you don't have your probe backwards before you say it's retroverted, because you may just have your probe backwards. So just double check, and if it's sealed that way, then you know, yes, it is retroverted. But again, this is anteverted. Retroverted on transvaginal is just going to look backwards. Cervix will be over here. This is the left side of the screen, right side of the patient. If you guys see that written anywhere on any of my tests, any of the textbooks, on the registry, if you see something say left side of screen, that's this over here, because this is the left side of the screen, the right side of your patient. Okay? Whenever it's doing that, it will specify left side of the screen. And so that's over here. This is right side of the screen. Okay, and here's a transverse of that uterus. And it makes it look kind of wonky. But again, just going straight across that midline. Okay. When a mass is found, where are we now?
On that little box.
It's still in the box. Okay, I see it then. Okay. So in the adnexa, this is that area that, if we're talking about in this class, the area around the uterus, and that's where the ovaries and the fallopian tube lie. And the reason why you check this, which this is lump ovaries and fallopian tubes in there, you want to check the size, shape, contour, and echogenicity of the ovaries, which we will get there. You guys will start imaging those after midterm. You want to see the position relative to the uterus. The ovaries can vary in where they are. Whenever you guys start finding them, they'll give you a headache, because someone may have easy ovaries to find, someone else may have difficult ones to find. We had, last time I taught it, there was someone whose ovaries sat right in their cul-de-sac. That can happen. In their posterior cul-de-sac, it sat right there. They thought maybe they had a tumor or something. It wasn't a tumor, just the ovary. Okay, ovarian size determined by measuring length of long axis with AP dimension, measured perpendicular to length. That's just, again, saying your measurements like this. You'll do that for your ovary, too. The ovary usually lies kind of like this, and so you would still do your length and your AP measurement just like that. Do length where it's longest, your AP wherever it's thickest. And then you will also do the width, and that'll be in the transverse or coronal view. Depends on what you're doing, transabdominal, transvaginal. And then whenever you do that using calc, a volume is calculated. It does the length times height times width, but it adds, or it multiplies like 0.5 to 3 or something to it. It's some special ovarian volume thing that the machine does for you. But it will only do it if you use the couch. So that's why I have you guys using couch, because you're going to have to do that out there, real world. All right, cul-de-sac. Evaluate the cul-de-sac for presence of free fluid or a mass. So on here, what is this cul-de-sac right here called? This is your uterus on ultrasound. Transabdominally.
It starts with an F, it has an F. No, it is.
Pouch of duck.
It was the F.
Yes, it is a pouch of Douglas.
Right there.
You get an A for enthusiasm. Another name for pouch of Douglas is the posterior cul-de-sac, because it is posterior to the uterus, so it's called the posterior cul-de-sac. It sits between the uterus and what is this? The rectum.
Is there another?
There is. Another name for the posterior cul-de-sac is the rectouterine recess or rectouterine sac or recess or pouch. I won't say process. No, it's recess and then pouch. And then you also have another sac. Usually whenever there's fluid here, you kind of see it more up here because the fluid, it'll go here first because pouch does the most dependent portion of the body. And then fluid, once it gets real bad, it'll kind of come around and it'll cap. And you'll see fluid up here between the uterus and the bladder. Let's say this is bladder. And what is this one called, this space?
Vesico-uterine.
It's the anterior cul-de-sac. Anterior cul-de-sac, posterior cul-de-sac, vesico-uterine sac, or recess or pouch, rectouterine. Because it's vesico, that's bladder, and then your recto, and then uterus. So if it says vesico-uterine sac, that's the sac between the bladder and the uterus. So if you can just kind of visualize, that's the anterior cul-de-sac. That's going to be anterior to the uterus, because it's between the bladder and the uterus. Let's see. Okay, if a mass is detected, document size, position, shape, echographic pattern, relationship to ovaries and uterus. This, whenever you see any kind of mass anywhere, you are always going to document its size. You're going to get all 3 measurements. You're going to get the 2 in long and then the 1 in transverse. Get your length and height and then your width or depth. You always measure it, find its position. Where is it? Is this mass also, you want to know what's it attached to? Is this attached to the liver? Is this attached to the uterus? Is it ovarian or is it on the spleen? You always want to check to see what this mass is actually attached to. You want to do the shape. Always do the shape because that's very important. A lot of malignant masses are irregular. Whereas if something is really nice and circle and round, and if it's anechoic too, that's the next echographic pattern, it may just be a cyst and not, cancer. So you always want to check the shape and also the echographic pattern or its consistency or, what is it made up of? What does it look like? If it's got black in there, that's fluid, and so it'll have a cystic component to it. If there's a lot of debris in there with the cystic component, it becomes complex. It could just be a complex cyst, or it could be something malignant. So that's where shape comes in. And if you see something that is just completely echogenic, there's nothing cystic in there, then it's solid. So you just want to you want to check to see what it's made up of. We can't actually say, oh, it is made up of squamous cells. We can't say that. I'm saying what is it made up ultrasound, is it hyperechoic, anechoic, hypoechoic, is it heterogeneous, other calcifications in there, things that we can say. I can't say, oh, this is it, this is what it's made up of cancer. No, we can't say that. Just what it looks like. All right, and then differentiate normal loops of bowel from a mass. How do you do that? Peristalsis. You check for that moving and that turning of what's in the bowel. Whenever you guys start looking for ovaries, bowel can be confused for ovaries. So just sit there and watch it for a second. If you're not sure if it's the ovary or bowel, just watch for a second. If it moves, it's bowel, it's not the ovary. Okay? I think that was a registry question in mine. It was what are ovaries commonly confused with? And it was bowel. Or maybe it was a test question while I was in the program. It was a question somewhere.
But
That's what I want to know.
that was a question on my second quiz in my third quarter.
What? Number 4. Next slide. All right, sonographic technique. So now we got to that little part. I should have labeled like how I would in my book. Actually, this was already kind of made. I just fixed it and made it go with what I wanted. Okay. When matched down on sonography, characterize the following features. We kind of already talked about this, but this one is specifically towards uterus. You want to know, is it uterine or extrauterine? Is this attached to the uterus, or is it, attached to the ovary? Is it something hanging off maybe of the fallopian tube? We want to get the size. We want to do the external contour. Is it well-defined, ill-defined, irregular borders? That is like the shape. The external contour, that's the shape of it. And then internal consistency, that's what it's made up of. We already talked about cystic versus complex. Predominantly cystic, that's probably just like a septated cyst. Complex on their twice. Predominantly solid, so that's predominantly solid. There's a little bit of cystic component in there, and then something solid is just nothing but tissue. There's nothing fluid about it. It's all just tissue and it's solid. Okay, here is what it looks like whenever you do transabdominal. So this is your patient laying down, and this is what it looks like on your screen. So this way you guys can just kind of visualize it, because I know whenever it can be confusing, like you want to move your probe up, but then your screen moves like this way. It's because you're moving your probe up, you're moving it up this way, up your patient, but this is superior, so that's why your screen's going this way, but you're going that way. Does that make sense?
okay.
Yes. So, superior, posterior, anterior, inferior. Alright? I know that's something that it's hard to get used to. Moving one way and then your screen's going the other way.
Can we turn the screen?
No, they're not that. You talking about like taking your screen right upside down? Okay. Not on those ATL. How are you going to do that? Those things don't do go up or down.
Don't work well with my ADD.
What, this doesn't?
Yeah.
It just takes practice. Like, really when you do those carotids and you're just trying to slide up, but you're going like up the neck, but then yet the screen's going this way, it's just like you're going this way and it's going that way. It just takes practice.
Yeah.
Yep.
That's all over long.
It just takes practice. Okay, but I think this is in your book though, is it not? It is. Yes. So if you guys need to just like take some time, process it, and think about it, it's just right here on 958. Okay?
Just stare at it for a couple hours.
That's what it takes. Look at it. Okay. And then I don't know why that was on there. I think I meant to delete these. That's TA. I wanted transvaginal. What? I deleted the transvaginal one? No, they don't have transvaginal.
I know.
Oh, yeah. Okay, we just haven't got there yet. Okay.
Backwards.
We just like got there.
Okay.
All right. Transabdominal ultrasonography. The transabdominal approach, again, that's looking at the female reproductive system, uterus, cervix, vagina, the full bladder, across the anterior abdominal wall. You guys are already doing that. It is, however, limited in patients who are obese. There's the sound wave has further to travel, so it gets weakened. It attenuates more, and so the echo coming back isn't as strong. It's not as pretty of a picture. We can't see as much detail. So transabdominal is not as pretty on obese patients. We can't see as much detail.
Where are we at?
Transabdominal top of 957.
I was reading, I couldn't find it.
Older patients who are unable to feel due to incontinence issues. So those that can't hold their bladder, you're not going to be able to get the bladder to cap the uterus, and you're not going to have that pretty picture either. Also, patients with retroverted uteruses. It's not, you don't get to see the endometrium quite as well, because the fundus will, well, if it's retroverted, the entire cervix and uterus will bend backwards. However, if it's retroflex, the fundus will bend backwards as well. But all of that makes it further away from the sound beam, and it makes it even harder to see. Yes, Emily.
Hey, what, I said it like you didn't do it. So, okay, when it's considered like looking at it this way, but you're going this way and this way, how can you tell whether it's levoverted or dextroverted or?
Well, how you probe it angle? It's okay. Hang on.
Like if it's just a rate, how we are standing right now.
Okay, say if your patient is up here on the wall and they are levoverted, their uterus is going this way, to get it in long with your probe, you're going to be angled this way to get it lengthened out. So see, I'm angling to the left, so I know if they're levoverted.
Yeah, but I mean, like, what does it look like on, how are you going to be able to tell? It looks like,
I can't tell. Because you get it on midline, it just looks like midline of the uterus. I can't tell if it's levo or dextro.
So we won't have to determine that.
No, but you can lie to me about it, and I will never know. But I do want y'all to know.
You can only do that
Well, I mean, when it's just like a one figure, it's just confusing because it's going this way or this way, and I would think it would.
Are you talking about in transvaginal?
No.
Okay, that's what I thought you were talking about now.
No, how we are standing.
Yes.
Yeah.
Yeah, I can't tell if it's going to be levoverted or dextroverted. You guys? Yes.
Okay. That's, yeah, that's
Yeah.
what I was trying to get.
I'll say either you guys probe backwards or it's retroverted. Yes.
Yeah, see, that's a serious question.
I'm still not sure what it was, but yes. Okay. All right, let's move down to the next paragraph. Skip that first sentence. The transabdominal exam is performed with a distended uterine bladder. Y'all know that. You must drink at least 32 ounces of fluid 1 hour before the examination time. That's what you need to tell your patient. If they're coming in for a transabdominal pelvic ultrasound, you need to tell them to drink at least 32 ounces of fluid 1 hour before examination. And chances are they're going to come in not going to be full enough. So you'll just have to send them back out to the lobby. We used to do it all the time when I worked at we'd send them back out to the lobby, have them fill back up. However, the OBGYN office was like, well, just go empty your bladder, do transvaginal. If they were, menarche, there wasn't anything preventing a transvaginal from being done. Okay. All right, but a full bladder, it displaces the bowel and any gas it contains from the field of view. So whenever you guys have like your uterus lengthened out right here, and then, uterus, and you see like all this black right here, and you're like, what is that? That's bowel, and it's shadowed from it. It's not supposed to be pretty. And then it blacks out right here too, because like all this is bladder. It's like what you don't see from bladder is going to be bowel. It's not going to be very pretty. Yes. Why are you laughing?
Because you're like on super speed.
You better shadow.
Sorry.
It's okay, no, it's funny.
Very.
And, okay.
We got a lot to go over.
I know, I do.
And look, we've been in here for how long, and we've not even done a full page. What are we talking about? Okay.
Bowel, not pretty.
Bowel. Okay, the poopage is on the side. And you got the shadowing. And so, and I've been asked this question a few times already. I'm like, what is this? It's because the bladder's not over there, and that's why you can't see it. So that's why if you get your bladder to full and to cap, then you can see all of this. Okay? Yeah.
It's a method.
It is. I'm not lying to you guys. Okay. All right, and it also flattens the anti-flex and anti-verted uterus. So you guys have seen whenever someone's not full, the uterus is more straight up and down. It's not pushed back like this. It's like up here, right? Oh, that's like something else. Okay. It's more this way. It hasn't been pushed back. by the bladder, okay? Moving on. The bladder is considered optimally full when it covers the fundus of the normal-sized uterus. Y'all already know that too. Whenever I come around and I'm checking to see if someone's full, I'm looking to see if the bladder has capped and come over the fundus of the uterus there. However, I know Jamie and Kim, you two don't cap. There's a senior that doesn't cap either. And it's fine, their bladder, not the bladder, their uterus, the fundus just comes up and it's very anterior, so you can see it anyway, because it's so close to the front of your body. And so you can still see it clearly. You may just have to increase your TGCs right over it to make it homogeneous with the rest of the uterus. Okay, down to the bottom, the last sentence of the second to last paragraph, it says, if there is any question as to whether a cystic structure in the pelvis represents the bladder or is, some kind of cyst possibly, have the patient either empty their bladder and then come back and check, or you can just hold the probe over the bladder where like the ureters come in and watch for those jets. I know some of y'all have already seen ureteral jets, like the urine actually go into the bladder and you see it shifting in there. Has everybody seen that yet? Yeah. There. Okay. It does. The uterus should then be identified in its long axis. This may not be in a true anatomic sagittal plane because the uterus can normally deviate to either the right or left. What is it called whenever the uterus deviates to the right? Dextroversion, or vertis. The uterus is extroverted. What is it called whenever it leans to the left? Well, I gotta make sure everybody else knows it, Emily. What is it? What? Levoverted, that's right. Okay. Moving on. Next page. Okay. Well, there's another transverse uterus and how you measure it. That's in your book, though.
What about endometrium in the middle?
Yes. Uh-huh.
Too big.
I don't know what medicine is. I didn't measure it. It looks chunky, Okay. Alright, so page 958. Once the long axis has been established, parallel sagittal scans are then obtained to the right and to the left. And that is meaning just you scan through the uterus. So you get your midline picture, and then you do like corresponding sagittal images. You're scanning through it and doing like as if, and you want to take your pictures. If you're somewhere where they do pictures, you may be somewhere where they do the captures and they do the clips. Either wherever you're at, that's what you're going to do. And that's where you just scan through the uterus and you're taking pictures, or you're clipping and showing you scanning through the uterus, because you got to make sure there's not anything throughout it. Because whenever you have that one midline image, that's just one slice of the uterus. That's not all of it. You have to actually take multiple images throughout each slice of the uterus, so that way the radiologist or the gynecologist, if you're working in a gynecologist's office, or whoever the sonologist is, so that way they can see each slice and they can confidently give a diagnosis of yes, this patient is within normal limits, or yes, this patient has a fibroid in their posterior myometrium. Okay. The adnexal area may be imaged by scanning obliquely from the contralateral side and scanning through the fluid-filled bladder. You guys did this last week. You have to go to the contralateral side, which is the opposite side. So if we're looking at the right adnexal, we come over to the left, look through the bladder, because that's our window. Remember, if you're looking for the clown in the driveway, you're going to come to this side to look over there, right? And then we're looking through a window, okay? And then if your driveway's over here, you're going to look this way, right? Okay. All right. I don't know, it's the first thing that pops in my head. Okay. Skip the next two sentences. The iliac vessels can be used as a landmark to identify the lateral adnexal borders. So I know some of y'all probably saw the iliac vessels while you were scanning. They kind of look, whenever you're doing the adnexa, you see like the bladders here. They'll kind of look like little vessels coming in over there. And those are your lateral borders of the adnexa. Whenever you see the iliac, you can stop, because that's as far as that adnexa goes. By again identifying the true sagittal plane of the uterus and cervix, so that's going back to that uterus's midline. If they're lavoverted, you'll slightly tilt this way, dextro slightly that way, or however dextroverted they are, maybe they are like way over here. However their midline is, you'll angle that way. That is their true sagittal of that uterus. And then if you rotate it 90 degrees, you'll get your transverse measurement, or your coronal if you're doing a transvaginal. Anatomic correlation is correct for axial scans when the left side of the screen correlates with the right side of the patient. That is going back to what I was talking about, like the left side of the screen, that's like this side of the screen. If this is, you draw it to the screen. Oh, there's the screen. Okay. So this is left side of the screen, so this will be right side of the patient. That's when you have the correct anatomic correlation. Okay? So left side of patient should be right side of patient should be left side of screen. Left side of patient should be right side of screen. Okay. Get to the next paragraph. Skip that first line. A routine protocol consists of longitudinal and transverse scans of the uterus. You need to really look at that myometrium, endometrium, cervix, the cul-de-sac, the annexas. You're going to get measurements of all the normal structures and all the pathology. Again, we talked about the length, the height, and the depth. So do that for your normal structures and your pathologic processes. And also you'll want to put color Doppler on everything. Make sure you put color Doppler on there, because malignancies have increased blood flow. A carcinoma is going to have increased blood flow. Also, inflammation is going to cause an increased blood flow as well. So always put your color on there. If pathology is present, this is on the next page, documentation of the right upper quadrant and bilateral renal areas may be obtained. That's because fluid processes from these can accumulate in these areas. Did I tell you about how that ectopic pregnancy that I had ruptured and I couldn't see anything because the uterus was so huge? It doesn't look like a ton of fibroids, and I couldn't, no matter where I angled that thing, that transvaginal as far as I could, I couldn't see anything. Or all I saw was a huge fibrotic uterus. Pulled it out, I looked on top in Morrison's pouch, huge blood collection in Morrison's pouch all the way around the liver. So if you can't see anything, I could have just stopped and said, I don't know, I can't see anything. Uterus is just really big, has fibroids all in it. But pull the probe out, check transabdominally, see all that fluid there. So then I could have said, yes, she does have this. It helped that she was hypotensive. Her blood pressure was dropping because she was losing blood. And it was because she had a ruptured ectopic in her tube. Okay. Transvaginal ultrasonography. Alright, so patient instructions. After the transabdominal study is completed, if you do it first, some places you don't have to do a transabdominal study, you just do transvaginal. But if they have had the transabdominal done, have them go to the restroom and then come back. But if they are just coming to you for a transvaginal, I would go ahead and tell them just to go to the bathroom real quick. Because if they had whipped before they went home, they could already fill back up. So have them go to the bathroom first. And then you need to adequately explain the procedure. They need to have great explanation about anything going inside, because they will flip out quick. Some people are just kind of going, like, okay, whatever. But a lot of times they just need a lot of explanation, calming down, especially whenever you pull that probe out.
What about, I know this is a weird question, but what about sex reassignment?
No. It depends on how their stuff is. If they have not had their stuff removed, if they're a boy, and haven't had it removed, then you'll just still do like regular stuff because they haven't had that reassigned. But I guess if they have had it, it just depends on their anatomy. if they've been given, like a vagina, I'm sure they haven't been given a uterus, I don't think they do that. Yeah. Yeah, or, yeah, you would just see like, yeah, you would just see a vaginal cup, which is next chapter we'll talk about. And then I don't know what, I mean, I don't know all about, do they get testicles, or do they just get a penis, or do they?
They probably have a sort of,
Or do they probably? You just, yeah, you may just need to ask.
they may try to Google.
Look in the chart.
They may try to Google it, I think they're trying to.
Yeah, I would just check the chart.
I mean, because you get that and you're like,
Like the rest of what other than testicles.
Yeah. Yeah, they do have those, they do.
Yeah.
Yeah, that makes sense.
Patients just know when they train
Yeah.
they
Yeah.
say.
Yeah, you're gonna have to ask. You're gonna have to ask. Read that chart.
Somebody's like cancer or
Yeah,
whatever.
depends on how much money they have.
Okay.
Anyway.
Right.
Moving on, Larry.
Of course.
Curiosity is healthy.
It was a good question. Interesting. May I put it on the desk? What do you do when a patient has had reassignment? You check the chart. You ask the doctor, are you sure? Okay. All right, so many labs require a verbal or written consent from the patient and examiner. That's most places. I don't know of anywhere that would just go straight to a transvaginal and ask the patient. Like the patient has to say, yes, okay, I'm fine with you doing this. Because that is like a lawsuit waiting to happen or something. If you forcibly, I mean, you can't do that anyway. Like you have to have the patient be okay with doing this study for you to do it. If they're not, just do transabdominally and get what you can. And if you are a male and doing a transvaginal ultrasound, Larry, you have to have a female coworker in there with you, not a female family member of that patient. You need to find you somebody and bring in there. If you're working at OB, well, you won't work in an OBGYN office because they won't hire you. They only hire female OBGYNs. They do, for that reason. They only hire women. We have an OBGYN site. We don't send male students. They won't take male students.
But the crazy thing is, you have OB doctors, male doctors all the time.
They have their nurse,
Yeah.
They have their nurses with them for everything. I've been called in before too, because the nurse was gone busy, and just come in and hang out. So I'm just sitting there, well, what's up? How you doing? You know, they're like, I'm a pastor. They're like, well, just hang around.
That is the fastest years.
Oh my gosh.
Oh my.
Yes, mine.
Well, the females doesn't struggle with that, have a male in there, or anybody.
No.
I don't know why. I just maybe don't mind them, I guess.
That is weird, though. The males is probably never. We don't have to have.
Yeah, that's what I'm saying. That's what I'm complaining about.
Well, see, I kind of want somebody in there with me.
I mean, if they can request it,
They
for
could
sure.
be kind of like, I mean, you know.
Yeah, what if
guys,
they come
like,
on,
especially
you
old
can
guys and
request
stuff.
it.
They kind of like somebody
Yeah.
to use.
And you can't, if you got somebody creepy in there, I'd give me somebody. Yeah, like I was doing a leg study on this inmate from the jailhouse, and I couldn't, he had his legs shackled, and so I had to help him take his pants off because I was doing his leg study. It was just a DVT study, so he couldn't cover any of this, so he's just like hanging out on the bed, you know, shackled, pants around his ankles, got his underwear on, and I'm just like in a dark, small room with him, trying my best to finish this leg study, and they have called me, like, I thought, I'm like, oh my God. I mean, he was a big guy.
What was he in there for?
I don't know, we're not staff. But he was this huge guy. He had long, wavy, dark hair. He looked like Samoan or something. I was like, oh my God. Like, he could, like, beat me because I'm like, walk the slide, like, hit the ground, leave an implant. So that was the quickest DVD study I've done in my life. But that's how you figure that out. And, anyway, he was perfect. He didn't say a word. He was just sat there and it was very well behaved. Yeah. Okay. That's why I did in the ER. I didn't even have it come up to me. So like, look, look at my tat, you know? So you need to keep a stash of like, you know, a knife, tattoos, like, oh, this is an inmate, and you put them on a little washer. Select things.
My Alice in Wonderland.
You are. We got some games.
She has to watch the camera.
Yeah, well, there were about 8 inmates that showed up, like, drunk. They drank a bunch of hand sanitizer. And so they had to come to the ER, and they're like lined up, acting crazy. I'm walking through them, what are they doing? And they're like, yeah, they just drank hand sanitizer. So like,
That alcohol, that like rubbing alcohol, can get people blind.
No, you can get drunk off rubbing alcohol.
Yeah,
It's just
not good. I don't
Very
suggest it.
dangerous. From being in, we had one of the girls drank a whole bunch of that, and she was paralyzed from the waist down for like a 6-month period.
Oh my
So she came back. I mean, all kinds of messed up stuff. Yeah, don't drink.
Don't worry.
Okay, moving on to hand sanitizer. Okay, again, transvaginal ultrasounds, we get much better detail because we can get closer to the structures that we're looking at. So we can use a higher frequency. Higher frequencies show better detail for superficial structures. So we got to get closer to it so we can see better detail. Whereas lower frequencies, they have a longer wavelength so they can travel deeper into the body. And they don't attenuate as quickly as a high frequency wave, right? Everybody know this from physics?
Yeah.
Yep. Okay. So high frequency probes, that's what the transvaginal is, and that's why we see such pretty pictures with the transvaginal. We can really see the endometrium really well. But however, we do have a limited field of view and penetration. You know, you can only move that probe because, I mean, it's in the vagina, it can only go as far as it can go. But it is, however, the preferred method because you can see so much detail with it. However, someone that has really anterior ovaries, it's going to be hard to see those ovaries transvaginally. However, since they're anterior, they're closer to the abdominal surface, so you can see them very pretty with transabdominal. So you just probe out, check transabdominally, and you'll get them pretty. Okay. Patient refusal, lack of patient tolerance, and age are reasons why you would not do a transvaginal though. Someone that refuses to have it, they're not going to get it. You do not give it to them. Lack of patient tolerance, that is usually secondary to like pelvic pain, from like really bad PID, or you know something else causing really bad pelvic pain. They're not going to be able to handle the transvaginal. And also age, again, you wouldn't do a transvaginal ultrasound on an 8-year-old. Or a 14-year-old that's not sexually active. You just wouldn't do that. Okay, probe preparation. Turn it down?
Turn it away from me? Okay.
That's cool right now.
Okay, this thing is about as old as I am, but this is a transvaginal probe, a really old transvaginal probe. Usually they're white. This one looks like it was white at one point. But anyway, to prepare it, you would put some ultrasound gel on the tip here. You see, this is where the element is. See, like the little rubber right there? That's where it's actually going, the crystals are firing right here, so the sound wave is coming from just this little part right here. So you would put some ultrasound gel on here, just a regular gel, just put you some on there, and then you'll take a sterile probe cover and you actually roll it on. It's just like a condom. You just kind of roll it on there, and then you would make it has like a little stretchy part that stays right here. Some come with rubber bands, and you have to like rubber band them in certain areas. You can either do it here to keep the gel up here so that way it doesn't slide down the probe part right here. So you can either put rubber band here or you can put it there. You just don't want the probe coming off in your patient. So make sure that stays on there, and then you'll have sterile gel that goes on top of the probe cover. So you've got regular gel, your sterile probe cover, and then you'll have sterile gel on top of that. Now you putting on the probe cover is going to kind of contaminate it, but try not to touch it too much. You'll do it with gloves. You can wear regular gloves, but make sure that the sterile gel, you don't touch that. But you'll insert this into the patient after you've done gel, cover, gel. Okay? Kind of the more sterile gel you put on the outside, the easier it is to get in there. Also, there's a way you can either kind of just take a quick peek, see, and stick it in there. You don't want to stick it in the wrong hole. Or you can kind of, this is what Miss McCullough has always done. I always like to look and then just stick it in there real quick. She always would start up top and then just kind of move down until she felt like the dip and then would put it in.
Every time I've ever had one done, they let me put it in.
Yeah, that's what.
Yeah, I mean, I always put mine in too. I never offered unless they're just like, oh my God, can I do it? Then I would let them do it. Because I had a girl put it in the wrong hole when she wanted to do it herself. And I had to pull it out, re-probe, and then I was like, well, it wasn't really right. This is Talladega, I'm telling you. So I looked and I was looking, I was like, what in the world? I just love Brooks and Dang it, so I pulled it out.
You didn't really?
Neutral. I told her in her vagina. I don't know why she put it in there. No, I didn't try to stick that in. No. No, I was the tech, I was not the patient.
And she put it.
The patient, she put it in herself. And she put it wrong. No. Come on, guys. Come on, guys. Stay with me. Stay with me. I don't know what she did. She was a younger girl. I'm just the one I told her it goes in your vagina. But maybe I didn't. I don't know, but she had it in
Okay,
the
we
wrong
can't
place.
stay with you when you're swinging that thing around.
But anyway, when it happens, you just have to pull it out, take the probe off, put another one on there, and then start all over. Okay.
Yeah, rare form.
What?
Yeah,
Like,
rare
like
form.
criminal. I know. Okay. Where are we talking about again? Where are we at on this?
Somewhere, like in somewhere.
Okay, we can do disinfectant. Another trick I'm gonna go ahead and tell you guys that I had to learn the hard way is that whenever you are dealing like an obese patient or just someone with really big thighs, where because they're in a stirrup, they're in pap smear position. You know, they're laid back, they got their feet in the stirrup, knees as far as wide as you can get them. Sometimes though, whenever you're dealing with an obese patient, the thighs will still touch. And so you can either take a gloved hand and kind of move the thigh over and try and get it in there. All I can tell you is use a lot of gel for that because the gel will catch on the inner thigh on its way in there. So I would just put a lot of gel on there. So that way, if you go ahead and do it, it's not going to embarrass the patient or anything. So just gel it up really well, and that way the gel that does get stuck on the inner thigh on the way in, you'll still have enough left over to actually get the insertion done. Okay. Let's see. A sterile external lubricant is then applied. All right, I talked about that. You put it on the outside of the probe cover. You have regular gel on the inside, sterile on the outside. This provides lubrication for insertion of probe and is especially important in older women or women, the postmenopausal. If you end up doing one on one thing that you will do if you work at an OB/GYN clinic is ultrasounds on postmenopausal women with bleeding. So you'll want to make sure you have a lot of gel because they don't have as much vaginal secretions as someone younger in like their childbearing age or in their reproductive years. Alright, examination technique. After the patient has completely voided, you ask your patient to undress from waist down. They're given either a gown or a sheet. We always have sheets. And I would just get them to sit on the bed and just kind of hang it over them like that. And then they'd have to they'd lay back and scoot their bottom all the way to the end of the bed. If not, your hand, whenever you're doing this, like if the patient's bottom is like up here and it's not to the edge of the bed, you've got the probate, you're just hitting this. You don't have a lot of room to move. You have to have them go all the way to the end so that way you can move your hand this way and you've got more mobility, okay? So make sure that they are all the way at the bottom of the bed. Okay, and most ultrasound beds now are already have the stirrups built into them. One of our beds on machine 6, that one has stirrups. And so most of them already are made that way. So you don't have to worry about putting the hips up on pillows and all that, because that, even then you have to push into the bed as hard as you can. However, you may have to do that if you go to like, I had to do one in MICU on this like elderly lady. They thought she had like endometrial carcinoma. And so I had to go up there. She had no idea what was going on. The OB/GYN was right there with me. If anybody knows Dr. Hancock, that was at Shelby. Now she's at UAB. But no, she didn't miss it. No, I don't know where she is. But this lady was there, and we lifted her hips as much as we could. She was a little old lady. And so lifted her hips, and I was scared. I was having to dig into the bed. But on top of that, she had defecated on herself while I was trying to scan her. So, not only was I having to dig in the bed, I was asking to dig in poop. So, but I had a glove on. So you guys that's another lesson there is just be prepared to work with anything. I was prepared to have to scan into the bed. I was not prepared to have to do it with like poop all over it. But you just have to adjust. Got to be adaptable. Here as ultrasound techs, if you guys are, especially if you're in the hospital, you've got to be able to adapt and to adjust to any situation. Okay? I walked in one time on a patient, he's, butt naked, standing on the side of his bed like this, and just ripped his IV out. He's like just standing there bleeding everywhere, like completely out of it. And I'm looking, I was like, oh, nurse! And then I was like trying to hold pressure on it. He was in MI, he was in the ICU, I keep saying MI, I'm sorry. That is a medical ICU at Shelby. So, does not need to be up, for one. They're standing up, bleeding everywhere. So, you just have to adjust. You never know what you're going to walk into. Let's see. Okay, an inverted uterus is going to be, again, we talked about it, transvaginal. An inverted uterus is going to look like this, transvaginally. A retroverted is going to look like this. So the cervix is on the left side of the screen, and the fundus is on the right side of the screen. Whereas inverted, the cervix is on the left side of the screen, fundus is on the right side of the screen. Okay, it just looks flipped backwards. Also, before I always inserted the probe, I'd make sure that I already had my probe in its correct orientation, because you can rotate this whole thing around. I'd always make sure that I had it correctly oriented, and then just go in, so that way I can see exactly where I am. Sometimes if it was retroverted and put on a different axis, I'd have to pull it over, check, and then okay, it's right. So make sure that you already have it right before you put it in there to save you any kind of confusion. And then again, you're going to scan through the structure to make sure that you get the uterus at each slice. Okay? Alright, next page. And this is just talking about the uterus is surveyed by scanning from midline to right and left. So you're just going to survey the entire uterus. You're going to take images throughout the entire uterus. That way each slice is imaged. So nothing can be missed. And then when you turn the transducer 90 degrees, you'll get the coronal plane in with a transvaginal. Your transverse view is actually your coronal view, technically. Okay. Over to the next column, last paragraph, second sentence. Says the probe may be inserted or guided by the patient, sonographer, or physician. Some places and some techs, they just go ahead and ask the patient if they want to insert it. I would just do it unless the patient asks to do it. Because if they're already nervous, I feel like that's just a little extra on them. Sometimes patients, it makes them more comfortable that they are actually doing it than someone else. So, and if they are really wanting to do it, they will speak up and they'll tell you. And if they're acting all nervous about it, then you can ask them, would you like to insert it? Would that help you? Some may say no, some may say yes. If yes, then just let them do it. All right, it should not be inserted beyond the external cervical os. So here, okay, so here's like our, if this is our cervix, this is our external os. So external os, here's our internal os. You do not want to put that probe into the cervix at all. You want it to stay completely in the vagina. If you push hard enough, I guess you can get it in there. But also, the probes, like this is a shorter probe here. The other ones are a bit longer, but if you are dealing with someone younger, maybe, that vaginal canals are usually about 9 inches. So I guess if you've got a big enough probe or they've got you're dealing with someone with smaller anatomy, then maybe you could. But either way, if you feel any kind of pressure, then you need to stop and pull back. That's as far as you need to go. All right, and to maintain the patient's dignity and privacy, the patient should be draped at all times. I always step out for the patient to get dressed. You always do that. Whenever they are undressing, you always tell them to take everything off, waist down, including your underwear. You have to specify including underwear. Because if you tell them to take everything off, waist down, they're going to take everything off but their underwear. Just to specify their underwear. However, I've had people just take it all off. So just say everything waist down, including your underwear, however you can leave your shirt on. And then just have them, and tell them, okay, and just have a seat on the bed, cover yourself up with this sheet. You have to be very, very thorough with whenever you explain the process to the patient. And anybody that's going to be observing the examination needs to be in there at the time. You don't want anybody opening up doors while someone's got their legs open. You need to, if you are a male and you're having your female coworker come in to observe, then you need to have them in there. If you guys are a student and you got to somewhere where they're doing a transvaginal, don't walk in there while someone's already doing a transvaginal. If someone says, you're like, well, where's so-and-so? Like, oh, they're doing transvaginal. Or if they were doing a carotid, then, fine, you can go in there. Don't do that for a transvaginal, okay? It's a dignity, it's a privacy, you just don't want to do it. It can make the patient just not do it right. Because what if someone was walking by and you open the door and they look and they're, oh my God, you don't know who's walking up and down those hallways. When you work in a hospital, you will find lost people all the time. That'll be like, how did you even get Pat here? Some people be roaming around, ended up all over the place. So make sure you just don't go in a room whenever someone's already started transvaginal. Okay. I would actually, we had a door that was locked when I worked in the OB/GYN office, and I would always lock it once we came in. Let's see, all right, scan protocol. Before recording any images, a complete survey should be performed. So this is just kind of scanning through the pelvis, scanning through the uterus, scanning through the ovaries, just kind of getting a feel for it, and then you start taking your pictures. And then you can rotate it as coronal and scan through that way. Down at the bottom, next paragraph, it says the thickness of the endometrium should be measured in the sagittal plane. So if this is our sagittal plane, we're going to be measuring just like this. You measure the thickness, not the length. Okay? And see, it may be helpful to use Zoom, and I showed you guys that you can zoom in on the endometrium. You can see it better that way. If you see it better zoomed out, like on a regular screen, that's fine. Do it that way. Whichever way is prettiest. If there's any internal fluid in the endometrium, you do not include it. Like if this is our endometrium here, and all of this is fluid right here, then you would just measure like this, and then you would add the two together, and that would be your endometrial measurement. Okay. Also, you're always going to obtain your standard images, and then you're also going to assess the pathology. Again, you're going to measure the color on there, check the consistency, all that stuff. You're going to do it for your normal structures and your pathology. I know I've already said that like 3 or 4 times already, but again, it's there again. Always use your color Doppler. You can use power if you need to. Power Doppler is not angle dependent, whereas color Doppler is. And then your pulse Doppler. You guys are already using that in vascular hemo. Did y'all just start using pulse Doppler? Okay. All right, moving on to translabial or transperineal. That's used as an alternative technique to transvaginal scanning whenever someone can't have a transvaginal ultrasound. And the most common scenarios when you wouldn't do that is premature rupture of membrane. That's when someone is pregnant and their water breaks too soon, is what that is. It's the amniotic sac, the baby, and it breaks. And you would want to avoid the prolapsed membrane. If you're cervical incontinence, so someone that has that incompetent cervix, and that usually happens around 20 to 22 weeks, that can happen, and so you don't want to mess with that cervix whenever it's not even really able to withstand the pregnancy. And also uterine prolapse. So what is uterine prolapse? Yes. That uterus is dropped, and it's like it can be hanging into the vagina. I worked with a tech. He said that he actually could see it like hanging out of the vagina, and so whenever that happens, you do translabial or transperineal. Okay, and that's where you just put it where the leg meets the groin, like in your groin. And it's easy to, you need to have partial bladder filling whenever you do that kind of ultrasound. It helps you to see better. However, you don't have very good imaging with that anyway. Usually you just do like a, transabdominal, you can see pretty okay, and then you just do your translabial or your transperineal the best you can. That might be, a head-on CT kind of patient. All right, so disinfecting technique. This is the use of an intracavitary device. It requires the prevention of cross-contamination between patients. So after you get through using your transvaginal ultrasound, you're going to put it inside it. It's typically what everybody uses around here. And then if they use something different, they usually call it still Cydex, kind of like chapstick is every kind of lip balm, even if it's not chapstick. So Cydex is just that disinfectant. But after you complete the transvaginal exam, the sterile probe should be removed, and there is a technique to it. Yeah, that technique. So whenever you are done, so you can either have one glove or 2 gloves. I'll show you with 2 gloves, because even if you have on like dirty gloves, there's a way to take them off too, to where you don't contaminate yourself. Okay. So if you had like the probe on here, you would pop the little, like the tight part of it that's around there, you kind of roll that off, and then you'd have it holding it this way, right? Because I pulled it off, I've got it, I'm holding it this way. Take your finger like this and pull it over. So that way you make like a sack. So that would be, the cover would be inside here, and then you can just pull it off and throw that in the trash. So this is like a little bag for the for the probe. And then also, I'll go ahead and show you this. If you are doing anything and your gloves become contaminated, like if you work in a pain center and you're doing procedures all the time, you would do like, you would take like one finger here and put on the inside and go like this. Wait, what am I doing? I don't even know what I'm doing. Yeah, okay. There we go. Alright, so I would take the one, just kind of pull it off and hold that in your hand. Just like you just kind of, you take it from the inside. You don't want to go on the inside of the wrist, because that's contaminating, because your gloves are already dirty. You just take this, wherever it's loose, and just pull it off. And then you put your finger on the inside, like this, and pull that off, and you make a sack. And then you throw them away, alright? So you make like the little bag, so you never touch the probe cover, and also it covers it up. You don't have a probe cover out in the open trash can. We had a tech that I worked with a tech that would do that, and I was like, oh my God. Patients would walk in and they'd see like a bloody, like, condom looking thing in the trash can, like, oh my God. And so I would always like throw the paper towels over it to cover it. I was like, why did I do that? You should go up. Anyway, it wasn't disabled, so I don't think it was there. No, I really don't think it was there. But anyway. And another thing is most places already use non-latex probe covers. You need, latex probe covers are cheaper than non-latex. So chances are they're going to buy the latex ones and then have special non-latex probe covers. However, most gloves are going to be non-latex. Or they should be everywhere. I think most places are using just non-latex gloves. But, most places already use the non-latex gloves. But, if they don't, you just need to make sure. Sterile gloves, however, do come in both, so you'll need to ask about patients too if you are using sterile gloves. If you're doing procedures, because you'll end up doing paracentesis and thoracentesis, so you need to know if your patient is allergic to latex or not. Another thing is, what was I talking about? Oh, transvaginal probe covers, what was it on a tangent? Always ask your patient if they're allergic to latex. So if they are, you need to use the non-latex probe cover. And if they aren't, then you can use the regular probe cover. I was working somewhere where we didn't have any of the non-latex probe covers anymore, so I had to use the non-latex glove. That looked country. So I had the probe on, it looked just like this. And I was scanning away, just doing what I had to do. And I was like, whatever it takes. Like, I don't know, slacking on the ordering.
Extra fingers flopping around in there.
It was like, I think it was like beating on like the little problem. Like, oh God, this is going through. Seriously. Anyway, that was just thinking on adapting to the situation. Gotta do it. Be able to think on your toes. Critical thinking. Y'all remember that critical thinking test you guys had to take? Yeah. Critical thinking. Gotta fix whatever's going on. Okay. So, again, once you get through, you take your probe cover off, take your gloves off. Okay. You'll wipe, no, so right there with the wind blew it. You'll just take like a paper towel. You can take either a paper towel or you can take one of those little wipes and just clean off what's visible. And then you would go put it in your Sidex. You don't put all of it in the Sidex. You just stick it down in there. And then you keep it in there for however long the manufacturer sets. It's usually between 10 to 20 minutes. For the Sidex that we always used, it was like 11 minutes. That's what we had to keep that's how long we had to keep it in there. However, there were people that would leave it in there for days. I'm like, where is the probe? And it would be like in the Sidex from like 2 days ago. Okay. And you don't do that because it will eat the probe. Okay? This will go away eventually if you leave it in there. That is some strong stuff. And it's usually at a separate station because this is it's a hazardous chemical. It's very strong. And so some places require you to wear like the gloves and the gown and the goggles. We got shows where we didn't do that. We just kind of put it in there and, we just hope to God we didn't splash ourselves. And you've got little test strips too that you have to check every time to make sure the Sidex is still good. And there's usually a Sidex log book somewhere that you have to say, oh, okay, this is the patient's name, this is the MR number, this is, what I did, and this is what time I put the probe in there, and, all that junk. It's like, you have to do it for a joint commission. They have a new name, I forgot their new name. But it's like who credentials hospitals, so that way Medicare, they can get money from Medicare and Medicaid. So they have to come around and make sure everything's like in order. And it's a joint commission, maybe, I don't remember the other name. But that is one thing that they always are sticklers about is the Sidex. I got grilled about it one time, and I answered the question correctly. But anyway, while the director was sitting right there, Susan Stanisky, y'all met her, right? When she was our last guest speaker, she was sitting right there and I answered every question. I said, yeah, boom, boom, boom. Like 11 minutes. I was like, it's back here. Here's our goggles. Here's our eyewash station. Anyway, thank you. Okay, and then whenever you get through, you can set a timer so that you don't forget. Whenever you're through, you go get the probe out. You need to rinse all that Sidex off of it and then dry it off before you use it on another patient. Don't, I mean, even if you do put a probe cover on it, don't go sticking Sidex in somebody. Just clean it off, okay? All right. Next page, sonographic evaluation of the pelvis. Yeah, we've done like 3 pages, 4 pages, 5 pages. Okay, move on. We gotta finish this chapter at least. Oh my God. Okay. Bony pelvis. Okay, there's a picture. Yep, and here's another endometrium that has the measurement. That's how you correctly do it. Here's transverse uterus. That's how you measure it correctly. Went through the endometrium. All right, bony pelvis. Sonographically, the sacrum may appear as a bright line with an overlying bowel shadow, and this is because, I mean, it's bone. You're not going to see anything. It absorbs all the sound waves. You know, it doesn't have anything returning. The obturator internus, sonographically, sections of this are seen at the posterolateral corners of the bladder, at the level of the vagina and cervix. It's hypoechoic, ovoid, and surrounded by the obturator fascia. The important thing about this one, though, is that it can be confused for like the ovaries whenever someone doesn't quite know what they're doing. It can be confused as that. But the obturator internus, that's the anterior lateral border of the pelvic muscles. It's on the anterior lateral wall of the pelvis. But it is posterior lateral corners of the bladder. Okay, so in general, it's anterior, but it's posterior to the bladder. All right, pelvic floor muscles, where the levator ani muscle is best visualized sonographically in a transverse plane with caudal angulation. So that's in transverse when you're angling down towards the feet. It's the most inferior aspect of the bladder, so just keep angling all the way to you're as far down as you can get. It's hypoechoic and hammock shaped. So there it is again. If you see hammock shaped about something or another, it's going to be the levator ani muscle. But here is the internal, obturator internus muscle here. So see how that can kind of look like it's kind of an ovary, but you have to get it in long-ended transverse. So if you can't reproduce that, and which you can, but it will be like all nice and laid back, so it'll look like an ovary. If you're getting confused, look for the follicles. Ovaries have follicles, so really look for those, and those will help you know if that is an ovary or not. Okay. All right. Again, the levator ani muscles. That is a group of 3 muscles. You got the pubococcygeus, iliococcygeus, and puborectalis. Again, that's that hammock shape. It's a group of 3 muscles that make up the pelvic floor, also known as the pelvic diaphragm. Hammock shape. Other muscles, the pelvic floor, the coccygeus and piriformis muscles. Those are not routinely visualized. You don't really have to worry about those. All right, next page. Iliopsoas muscles. Here's our levator ani muscles. See, these can kind of be mistaken as ovaries too if you're not sure where you are. I mean, this is the vagina, you get some rectum. This is not where you would normally see ovaries. Even though they can, ovaries are mobile and can be in different areas, this is not where you would be. All right, the iliopsoas muscles can be seen in the greater pelvis. What's another name for the greater pelvis? False pelvis. The iliopsoas muscle is a combination of the iliacus and the psoas major muscles. So remember, if you just kind of think all the muscles are part of the true pelvis except for the psoas major and the iliacus muscles. But those together make the iliopsoas. Right? You just kind of smush their names together. You get iliopsoas, and those are just the false pelvis ones. Kind of easier to remember that way. You just remember the false ones, and then all the rest of them are true. All right. On ultrasound, the liquids muscle is discretely marginated and hypoechoic. So see how this is hypoechoic compared to the rest of the tissue around it, and it's kind of got its own little space. You can delineate it, kind of starts to fade in, but you can see clearly where that is. Okay. Pelvic vascularity. I've already talked about a lot of this vascularity stuff, but let's just go through it pretty quickly. The next paragraph, the next column, says because the Doppler velocities are assessed as ratios, the values are angle dependent, or angle independent. To obtain accurate Doppler velocities, it is critical to have the Doppler as parallel to the flow as possible. You guys probably have already talked about this in hemo. You need to have that angle correction stick as parallel to the walls of those vessels as possible. The internal iliac vessels are the landmark of the lateral pelvic wall and ovary. Again, we already talked about this. The internal iliac vessels, also known as what? Hypogastric. This vessel is commonly seen lateral and deep to the ovary. So whenever you see that, you know that you need to come back in if you're looking for your ovary. Let's see, down to the next, get the next paragraph. The vagina has two sources of blood, just like the ovaries. The vagina gets blood from a branch of the uterine artery and a branch of the internal iliac vessel. The ovary also receives dual blood supply through the ovarian artery and also a branch from the uterine artery. The ovarian artery and the uterine artery kind of anastomose, and so the ovary gets its blood supply that way. The blood flow of the functional ovary varies with the menstrual cycle. So whenever the ovary is growing and it's about to ovulate, that's when it needs more blood flow because it's having to work more. Just like whenever you eat, your bowel needs more blood flow, your small intestines need more blood flow. That's why the SMA changed. We'll get there. Let's see. Increased blood flow to the ovary in the late follicular and early luteal phases. That's you'll get more blood flow, and that's around that ovulation time. So that's when the ovary is really going to have increased blood flow. You put that color Doppler on there, it'll light up better. You'll get more blood flow. And whenever you Doppler it, you'll have a low resistance pulse waveform. Have you guys talked about low and high resistance waveforms yet? Okay. Well, you'll and then a low velocity, highly resistive flow pattern is shown during the follicular phase. So you'll have, your velocities won't be very high, and they'll be, high resistance. So you'll get more blood flow towards ovulation. A normal pregnancy causes persistent, low resistive corpus luteal flow throughout the first trimester. So whenever you ovulate, that luteinizing hormone starts getting produced and causes luteinization and causes that follicle, that Graafian follicle that's ovulated will become a corpus luteum. And that corpus luteum produces what? What hormone does it secrete? Just progesterone. Yes, the corpus luteum secretes progesterone. And you will keep that until either it's time to start having your menses and you have your cycle, or if you're pregnant, that corpus luteum will keep going until throughout that first trimester until the placenta is nice and formed and can take over. But again, the corpus luteum is having to work, so it's getting extra blood flow. And so it can have like that ring of fire around it. It's going to have increased blood flow around it. Whenever you see that, that's what an ectopic pregnancy also has, is like a ring of fire. So just don't get it confused. Okay. All right, so moving on to the uterus now. The uterine muscle consists of 3 layers, the outer cisterosca or the perimetrium, which we don't visualize sonographically. The middle layer is the myometrium, and that is it's homogeneous, very smooth borders. That's all this right here. All this is myometrium. And then you have the inner layer, which is the endometrium, and that changes according to the cycle that you're on. The normal arcuate vessels are often seen in the periphery of the uterus. The arcuate vessels, or the arcuate arteries, they encircle the uterus. They go around the outside of the uterus here, and you can see those on ultrasound. they've got them lit up here in figure 4023. The radial arteries arise at multiple branches from the arcuate arteries. So once we get from the uterine arteries, and then you have the arcuate arteries, which actually can penetrate in there, and they encircle the uterus. Then the radial arteries come off of those and actually radiate towards the endometrium. Do you think radial arteries are radiating? So I don't think I could get my thing up. No, it's in chapter 39, right? Yes. So that one was able to get up on portal. So all this blood flow again is on portal. It's covered in chapter 39. Okay. So then the radial arteries, they travel to the endometrium, and then before entering the endometrium, the radial arteries give off these straight and spiral arteries, which actually supply the endometrium. So it goes arcuate arteries, radial arteries, and then your straight and spiral arteries. Next column, down a few sentences, says calcifications may be seen in the arcuate arteries in postmenopausal patients. So you'll see bright echogenic little spots, little focuses, or foci around the outside right here. And that's all that is it's just calcifications in the arcuate arteries. And it's just a normal postmenopausal thing, because you don't need as much blood flow to your uterus anymore. All right, so down a few more sentences. Uterine perfusion, which that's the vascular blood flow within the myometrium. Perfusion is just talking about the blood flow that you're receiving. So uterine perfusion, that's the blood of the uterus that's getting. It can be assessed by Dopplering, with color Doppler, pulse Doppler, power Doppler. The body of the uterus is separated from the cervix by the isthmus, which we've already talked about this, and that's actually where the uterus bends, if it's going to be anti-flex or retroflex, it bends at the isthmus. Let's see.
Is that not what I said earlier?
I don't know.
You did say that earlier. That was what she was trying to read out.
Anybody bring any shot records today?
Oh, I have a picture of mine here for you.
Just bring them by the office before you leave. If you didn't bring them, get on it, because they're gonna be here Monday and Wednesday of next week to give everybody what they need.
I gave mine to Mr. Fuller this morning.
What you need, Emily? What you need?
I didn't need nothing.
Just want to know that you guys.
I don't know.
I think yes, you said there was not the answer you were looking for.
I said it was earlier.
Oh, I can remember what I had on my desk 8 years ago. I'm interested in. All right. So, the body. Okay. You can frequently see Nabothian cysts, which are like epithelial inclusion cysts or cervical inclusion cysts. There's our arcuate arteries there. I can't keep up with these. But here's some arcuate arteries with color flow on. These look like cysts, right? You put color Doppler on there and they light up. And you know they're not cysts. They are arcuate vessels. Oh, here's that picture. That's in your book, though. Okay. So again, Nabothian cysts, these are cysts around the cervix. They're, not a big deal. They're benign. They are generally 1 to 2 centimeters wide. They're not usually very big. They're anechoic, smooth-walled structures with acoustic enhancement posteriorly. Those are typical cystic components, cystic characteristics. That's what you see sonographically. And they, again, are of no clinical significance and generally are not measured. I always would measure the biggest and the smallest, because usually there are multiple ones. I would always just measure the biggest and smallest and then document it. Here's one that does just have one, and that's it measured. Against a cyst, you would measure that way too, but well. And then you turn it transverse and measure the width. I don't know. Here's another, this is a transvaginal ultrasound with multiple Nabothian cysts. Again, since there's just 3, I would just measure those, just as the greatest measure cysts. Okay, so the cervix is fixed in the midline. We've already talked about that. That's the only part of the uterus that is firmly in place. But the uterine body is mobile, and it can lie obliquely to either side of the midline, which we talked about that, either dextro or levo. Flexion refers to the axis of the uterine body relative to the cervix. So that's where the isthmus is. That's where you bend. So flexion, if you're anti-flex, the fundus is going to tip over towards the cervix, or if you're retroflex, you'll tip backwards to the cervix. Whereas version refers to the axis of the cervix relative to the vagina. Because with version, the cervix and the entire uterus is going to tilt either forwards or backwards, depending on if they are inverted or retroverted. The uterus is usually anteverted and antiflex. That's what a normal, typical uterus looks like. It may also be retroflex, and that's when the body tilts backward because it's bent at the isthmus. Or it can be retroverted, and that's where the entire uterus tilts backward. The fundus of a retroverted or retroflexed uterus is harder to see transabdominally because, again, it's further back towards the rectum, so the sound wave has more to go through, and it's not going to be right there beside, up against the bladder. So it may appear hypoechoic. It may actually look like a mass. Like, oh my gosh, there's like a fibroid or something hanging off. But no, it's just that the uterus is retroverted or retroflexed, and it's bent backwards, and it'll just look hypoechoic. All right, the transabdominal technique is the best way to measure the cervical fundal dimension, because if you can see, like in this image, you can't quite see where exactly do I go, with the fundus. So to get the actual length, it's actually better to do it transabdominally, because you can actually see where cervix to the fundus is. And then if you have someone like this one has like a bigger uterus, because it's like hanging off up here, and then you don't even see much over here, I would get my details that I need to get through here, and then I would take the probe out, look transabdominally, and get it measured. And again, the length is always measured from fundus to cervix. Okay. Again, the size and shape varies, and it's related to age. Someone with an 8-year-old is going to have a smaller uterus than a 28-year-old. And then also parity, someone that has had one child is going to have a bigger, or someone that's had, one child will have a bigger uterus than someone that doesn't have any children at all. Let's just talk more about the measurement that you guys know how to do. All right. Under endometrium. The endometrium consists of a superficial functional layer and a deep basal layer. All of this is back in chapter 39 as well, so this is just like review. But during menstruation, that's your days 1 through 4, or 1 through 5, or 1 through 7 if you have like a long cycle. The endometrial canal appears as a hypoechoic central line representing blood and tissue. That's early on, but as you go through your menses, you lose that, and so towards your late menses, early proliferative phase, you're just going to have a thin echogenic line. And so this is what you're going to look like during menses early on. You're going to have, blood in there along with the endometrium, but as you bleed, it will thin out, and it will become a thin hyperechoic line. And so whenever you get like your early proliferative phase, you're just going to have a bright echogenic line. I'm just going to turn this up. You'll have a bright echogenic line just going through right there, and that's early proliferative, maybe even late menses if someone's still spotting. And so I changed this from the book, because the book just went straight from early to late. I was like, there is a mid portion there. So, proliferative phase, I made, it's about 8 to 11 days. That's like that middle area. The functionalis layer, which is the functional layer, becomes hypoechoic, and it becomes kind of like a halo around the endometrial cavity, which is actually a bright hyperechoic line. And the basalis layer is real hyperechoic, so that you end up with a 3-line sign. And that's what you get here, is that 3-line sign. And this right here is in your book. And so here's someone that's in their proliferative phase. So this is a zona basalis, or the basal layer, the deep layer. This is the functional layer. This is the endometrial cavity, again, functional layer, and the deep layer, or basal layer. Okay? The functional layer is also called the superficial layer. So that's proliferative phase. That's like mid-proliferative phase. And then early proliferative phase, this is going back to what we just talked about. If y'all need to go, people can go. I don't know why we can't have finishing. We need like another 4-hour class for this.
Now, you said you couldn't put this one up on the.
It won't let me. But I can save it. If anybody has a jump drive, I can save it onto there.
If you go jump through.
Well, I can bring, I'll bring mine.
Yeah,
Is anybody staying?
I got it.
Yeah.